I am Fiona Garner, Executive Director of Clinical Development and Translational Medicine at Partner Therapeutics. I'll briefly discuss the key points of our recent article, which discusses the use of Sargramostim combined with immune checkpoint inhibitors in metastatic melanoma, authored by Dr. Tarhini, Dr. Joshi, and myself, and recently published in the journal Immunotherapy. In this article, we reviewed the clinical studies of Sargramostim, a yeast-derived GM-CSF for the treatment of advanced melanoma as monotherapy and in combination with ipilimumab. We also reviewed the preclinical and translational data demonstrating Sargramostim's potential mechanism of action that synergizes with immune checkpoint inhibitors to enhance efficacy and reduce treatment-related toxicity. Over the last decade, immunotherapy and targeted therapies have revolutionized metastatic melanoma treatment, resulting in prolonged survival of many patients. Yet these treatments are not curative and additional therapy is often required. Primary resistance to immunotherapies occurs in up to 50% of patients, leading to poor outcomes and reduced survival. Immunotherapy is also associated with the development of immune-related adverse events. The development of these toxicities may require dose reductions, treatment interruptions, or discontinuation, and in some cases can be severe. So despite the improvements seen with these therapies, there remains a clear need for treatments that improve survival and reduce treatment-related toxicities. Sargramostim is an immune modulatory cytokine that bridges the innate and adaptive immune responses by activating neutrophils, macrophages, and dendritic cells, which then enhances antigen presentation and activation of T cells. Sargramostim has been evaluated in a number of clinical trials as a means of boosting immune responses, reversing immune tolerance, and enhancing anti-tumor efficacy, particularly when used in combination with other immunotherapies. The table here summarizes the clinical and immune response findings in advanced melanoma trials which demonstrate the efficacy of Sargramostim when used alone, as well as in combination with immunotherapies. The E1608 study was a phase 2 study evaluating the combination of Sargramostim and ipilimumab in advanced melanoma patients. The addition of Sargramostim to ipilimumab significantly improved survival from 12.7 months to 17.5 months with a hazard ratio of 0.64. Importantly, the addition of Sargramostim significantly reduced ipilimumab-related adverse events. In particular, decreases in the most severe treatment-related adverse events were specifically noted for pulmonary and gastrointestinal toxicities. The improved toxicity seen with the Sargramostim combination enabled more patients to remain on ipilimumab treatment for at least 4 cycles. The proposed mechanism for improved efficacy of checkpoint inhibitors when combined with Sargramostim is illustrated in Figure 1. Sargramostim improves tumor-associated antigen presentation through the maturation and recruitment of dendritic cells in tumor-draining lymph nodes and in the tumor microenvironment. This enables enhanced priming and activation of T cells, which then synergize with the action of anti-CTLA-4 or PD-1 antibodies. Combining these therapies can stimulate an increase in tumor-infiltrating effector T cells, leading to tumor inhibition and acquisition of long-term anti-tumor immunity. The majority of patients receiving immunotherapy will experience one or more immune-related adverse events. Most are low-grade events. However, severe events may lead to treatment delays or discontinuations. The figure here illustrates the role of GM-CSF in the amelioration of immune checkpoint inhibitor-related adverse events. GM-CSF can repair and restore lung and gastrointestinal homeostasis. In the lung, GM-CSF is essential for normal alveolar macrophage function, surfactant homeostasis, and regeneration of alveolar epithelium. In the gastrointestinal tract, GM-CSF can induce tolerogenic dendritic cells and regulatory T cells that dampen local inflammation, thereby protecting and healing the intestinal mucosa. The data in this review support the idea that combining Sargramostim with ipilimumab results in an additive or synergistic enhancement of anti-tumor activity in advanced melanoma, and this may be true for PD-1 inhibitor-based combinations as well. The potential of Sargramostim to ameliorate immune checkpoint inhibitor-related toxicity may represent a significant clinical benefit, which may allow patients to remain on immunotherapy at the indicated dose and duration, potentially maximizing efficacy while reducing toxicity. The benefits of combining Sargramostim with immune checkpoint inhibitors may not only be limited to patients with melanoma, and there are ongoing studies in other tumor types, such as advanced biliary cancer and non-small cell lung cancer. The therapeutic paradigm for advanced melanoma will likely continue to evolve towards greater use of combination immunotherapy regimens, including novel agents like Sargramostim, resulting in greater efficacy, reduced toxicity, and prolonged survival. We invite you to read and review our review and contact us with any questions.